Hello, everyone, and welcome to episode 3 of season 3. This is like a lucky episode because we've got our 3 and 3. I'm really excited because I have two guests. I turned the page on Daniel and I told him I wanted to interview him for this episode because he did something pretty cool that I'm excited that he can share with everybody about today. And he also brought a guest from Vanderbilt, Julia Rothschild, who also participated in this project that we're going to talk about today. But thanks for letting me turn the page on you here, Daniel. I'm really excited.
Well, thank you for allowing us to kind of share our experience. And before we get into it, just for everyone that may not know, I am an assistant professor at Vanderbilt University. I do some clinical work, but a lot of my work is also research-based. And so kind of want to give you that backstory, and I will let Julia introduce herself and kind of talk about her where she stands in the program and just kind of her perspective on things.
All right. Well, hi, I'm Julia. I am a current second-year rising third-year audiology student at Vanderbilt, and I was lucky enough to go to Poland with Daniel and two other students.
So yep, there you have it. We were kind of introduce what this episode is going to be about. We had the unique opportunity to join forces with Northern Illinois University, their Hard of Hearing program led by Dr. King Chung, to travel to Poland, Kharkov, and provide hearing and what we're going to be talking about, vestibular services to the Ukrainian refugees over there. And so we have a lot of information to share. And so I will let Liz kind of direct kind of the questions and try to just from the standpoint of what she's most curious about and what she thinks all our listeners and the audience would like to hear about this trip.
Yeah, selfishly, I feel like this episode is for me because I haven't had time to catch up with Daniel. And I was like, wait, I'll just interview you. But I am super intrigued by this idea of going to different places to provide vestibular evals, because as far as I know, I think this is the first time that I heard of a group going internationally to provide vestibular. So tell me, how did this opportunity come up? I'm very familiar with hearing, researchers and clinicians going to different countries and fitting hearing aids, but how did this opportunity get vestibular in the loop?
Right. So it really all comes down to Northern Illinois University's Hard of Hearing program. Dr. Chang has kind of done this, and she's visited over 8 countries for the last decade, going to different countries, providing hearing services, collecting information on individuals in need. So, I mean, that program in and of itself has provided hearing services for over 4,000 individuals across many different countries. And I was fortunate enough as an AUD student there to go to Australia as part of the trip in 2016. And so as alumni, she regularly invites, former alums on these trips. And, I thoroughly, it was the first trip that I had went on was absolutely amazing. So I always kept an open mind to go in again. And to hear, they recently extended their services to Poland to help the Ukrainian refugees. And the first for the hard of hearing side of it, for the hearing side of it, they were actually going over there and providing and fitting hearing aids on these these refugees. So that was a first for them as well. So they in November of last year, they started these regular trips to Poland. And Dr. Chung, reached out to all the former NIU alum. And I was like, I would love to go and, do my part, and just provide what help I can, except, I don't even, it's been several, 5-6 years since I fit a hearing aid. So, I may not be much help there, but is there an opportunity to, provide some type of, vestibular evaluation? Certainly I had an inclination that, some of these individuals with primarily hearing loss, a subgroup may have had, dizziness and balance problems as well. So, we probably back in February or March, I had a case history form translated that Dr. Chung was able to administer to the refugees. And sure enough, a significant amount of them were also experiencing, symptoms of vertigo, imbalance. And so I knew that there was certainly a need. And then that brought us to, okay, how do we actually set this type of trip up? But as far as how did this come about, that was sort of how the initial opportunity presented itself.
Yeah, that's super interesting. And like some of my initial thoughts, because I know we had chatted about this back in like probably March or April, my initial thoughts were like, it kind of makes sense that you can take vestibular diagnostics on the road. And in one way, it makes a lot of sense. In other ways, there's a lot of challenges. But many times I've always wondered about these trips because follow-up with these patients is really difficult. But surprisingly, in vestibular, we are not used to having a ton of follow-up with our patients. We're there for diagnostics. So it does kind of make sense that we can still provide that diagnostic edge and not require a ton of follow-up necessarily. Yeah. So it kind of fits better than I thought once I started thinking about it. Tell me a little bit. So the other thought that I had immediately was about the logistics. So you've already talked about like the case history form and the language barriers, but what were some of the other things, at least in preparing for the trip and setting up the logistics of the trip, that you had to think about?
Yeah. Well, Julia, it was all smooth sailing, right? So yeah, the logistics was the other hurdle and the other challenge. First and foremost, I needed to see if this opportunity was even possible. I initially envisioned, going, taking some audiology students as well, potentially even a PT colleague. But of course, money makes the world go round to some degree, right? So there certainly had to be some type of funding source. And, certainly, who do I know that, who may have, some great connections. So Liz, you want to take it away with some of your support and inner acoustic support. Because this trip would not be possible really without the support of inner acoustics and you to be able to help us with everything that we needed to kind of go abroad.
Well, it's definitely not one place to talk about, but I will mention, I mean, I had to think creatively too, because even I obviously work for equipment manufacturer, but I had just happened to see that Demont, which owns Inner Acoustics, had a listing for their employees. They do a lot of donations, and a lot of times you can help decide where the donations go. That's part of an employee benefit. So I'd happened to see that they were doing relief for Ukrainian refugees, and you could submit grants. So like Daniel and I worked on a little grant together and got that through, which could provide funding for you and some students to go. And then from the equipment standpoint, I want to know a little bit more about what protocols you had in mind, but sure. I helped secure some equipment for you to borrow and take along too, which, our equipment is not all portable. So it definitely was a challenging thing, but talk to me a little bit about protocol or what your ideal setup was.
Right. So what we wanted to do is essentially, obviously we're limited out in the field. And the two major questions that I had was there a need in this population? I kind of answered that with those translated case history forms, but I wasn't really going to know until we got over there and started testing. The second question that I wanted to know was vestibular testing really possible out in the field? I hadn't really heard, you had mentioned this before, but I too have never really heard of, this type of testing being done out in the field. So that was those were the two main questions that I had. And so I wanted to kind of come at it. How can we best mimic creatively, a traditional vestibular evaluation as best we could? And so we did have three general sections to our assessment. The first being just a balance assessment a balance screening rather, that consisted of a modified CAT sib. For our foam, we always joke about this with me and the students because we snagged some pillows from the Lufthansa flight on the way over there. So we often say that the trip was also sponsored by Lufthansa. So so we had some pillows that they handed out on the flight that actually worked quite well. So we did a modified CAT sib followed by a sitting to standing screening, kind of had the patient 5 times, go from sitting to standing. If they were above the 14.5 second cutoff, we consider that to be an abnormal screening. And, a lot of these assessments, we wanted to meet with our physical therapists at the Pi Beta Phi Institute. Holly Cawthon, she's a vestibular physical therapist. She's absolutely wonderful. And so she gave us a lot of great tips along the way, especially when we were, counseling patients, providing them, different translated handouts. And we can get to that. We were able to kind of provide some VRT exercises, some balance exercises. So Holly and our physical therapy colleague was absolutely a key component to this experience. So again, the first kind of phase consists that was sort of the balance screening phase, and then that's what kind of brought us into the equipment that you provided. And we did have the visual eye goggles that we were able to do an ocular motor screening. So we did a bedside, gaze, right, left, up, down. We did some saccade testing where we had the patient we kind of bounce back and forth between our finger and our nose in different directions, just to kind of look for any gross abnormalities. And then we, followed by a smooth pursuit. And then what we ended up doing was testing VOR suppression, and, again, more creative ways to go about this, but we ended up putting the visors on, having the patient move their head from side to side, just checking to make sure that a VOR was present. And then we turned on the fixation light while we were having them do that. So just looking for a gross suppression of the VOR. And that kind of consisted of our second phase, so this ocular motility phase. And then that allowed us to kind of move on to our full vestibular screening, which was, checking for spontaneous nystagmus, doing a bedside head impulse test, doing head shake, doing a Dix-Hall-Pike, doing some positionals, and then finishing
calorics, of course.
no calorics on this trip, but really just finishing up with dynamic visual acuity, and that was kind of our gross assessment of whether something was compensated or uncompensated. So I just realized I am talking too much. And
good. I know. I've got this, Julia, from your perspective, because you were doing a lot of this testing. So just from a test instruction, talk to me about some of the challenges, what went well, maybe what you would have done differently, or what you changed throughout the week.
Well, we did actually change things even after the first day of running through the protocol with a real patient. We had obviously practiced on campus prior to leaving, just getting through the flow, but when you're hands-on, you're in the field and you're in a different environment, that's not ideal for test setup. We just swapped the order of our test protocol to make it more fluid for the patients, because we realized, hey, we can instruct them, follow my finger, and then continue with one set of instructions for a few tests, which we thought that was time efficient as well as easier for instructing, especially with a language barrier. Over time, we also realized you can give patients instructions without using language. You can just say, watch me, I'm going to get on the pillow, keep my eyes open. Giving nonverbal communication, especially with people with profound hearing loss, was a really beneficial way to, adapt in that new environment. And even just, making decisions in that moment, saying, oh, right now, let's do a Fukuda as well for this specific patient based on their case history and what we're finding. So, of course, it's challenging, you see any patient, but I think the more hands-on we were, the more experience we got, and we're able to really adapt to a protocol that we felt was efficient, giving us the information we needed in a time-effective manner. Was challenging, but totally by the end, we got it down to a science.
Yeah, and I think that really speaks, when you're put in these environments, you have to be so flexible with what you would usually do or say with a patient. It probably really develops your skills a lot more than you get traditionally in a clinic that's very controlled environment with all the equipment you need. So talk to me specifically, you've already mentioned grabbing the pillows from the airplane to use as foam. Were there any other limitations like performing positionals or hall pikes where you had to be a little bit creative, not having tables, etc.?
We used a table that was there. But I think something that we did when we first saw the space we were going to be in was figure out where we were going to do what testing. So where were we going to do the balance testing? All right, one spot right there. That's where the pillow will be in a chair. Then we'll have them move over to another section that had a nice flow so that it wasn't fully, getting in the way of everyone around us. And then, putting the goggles on, keeping the goggles on for the rest of testing to make it easy for the patient, easy for us. And yeah, definitely not the most ideal, but you work with what you got, and we were able to, feel confident in that way.
Yeah. And so, I mean, the space that we were operating in was relatively small. There were two small rooms, and right in the center was this kind of a larger room where we thought our setup would be, or at least most sufficient. So there were certainly a lot of different stations going. There were 10 people that went on this trip. So me, three of my students, and then 6 other audiologists, including Dr. Chung. So certainly there were a lot of a lot of back and forth. We had to try to find ways where we were not getting in the way, because patients were going from hearing tests over right to the end of the other table that we were doing Dix Hallpike on. One end of the table we were doing Dix Hallpikes, the other end of the table they were fitting instant molds for hearing aids. So we had to try to maneuver and figure out what the best setup was. But I would say right after, the first few patients, we were like, okay, this is kind of how the flow is going to be. And then it kind of just took off from there. Thankfully, actually, our first day was probably the slowest day. I think we saw the fewest amount of patients that day. But as we kind of trekked on towards the end of the week, we were seeing quite a few patients, pretty back to back. And so it was nice that we were able to kind of figure out our space and our flow as we went on.
I think we did chat like at one time, right when you got back. And I think you had mentioned you had split up the vestibular assessment into 3 of those stations like you described. And obviously, Julia, you were one of a few students. So do you feel like having stations where a patient could go around was much more efficient, time efficient, or what was kind of your decision-making behind doing that type of flow?
I think it was just easier for us to break it up based on what we were looking at. So, and also with the number of people we had, one student would be running the balance screening, then we would have another one take over for ocular motility, and then we could get the room reset up for the next patient. I think it just broke it up nicely based on how many tests we were doing within each of those categories, but it also kind of gave us a time to be like, all right, this student is looking at the computer right now, and just have a nice flow for us to document what we were seeing, and then you could start the next patient if there was one. So yeah, I feel like just having the different stages was beneficial, similarly to for the hearing tests, and then they would go to get the hearing aids, then the instant mold and counseling. Yeah.
Just nice. Interesting. Yeah. And it's not uncommon. I've heard of clinics that even split up vestibular testing like that, or hearing testing like that, where, people will have their specialty, or, one audiologist will do the VEMPs and then they'll send along for the rest of testing. So I was just kind of curious what your thoughts were, because that's different maybe than how I was trained, where no matter what, it's you doing the whole thing. Do you feel like patients, had any difficulty, not having the same provider going through those 3 stations? Were there any challenges there?
I think it was beneficial for us because we all got to be hands-on in some way for each patient. Otherwise, there would just be one person taking you through and then a few others watching. And I think it gave everyone a purpose to be involved with every patient. So it allowed everyone to interact with them for one, and then, counsel with them and, really interact with them instead of just standing there and watching.
Yeah. And I think really too, from like a education, clinical practice perspective, not only, was everyone able to we sort of introduced everyone at the beginning of the patient's appointment. But then it also allowed, I think, for each student to get comfortable with their station. Every student had the opportunity to kind of dedicate themselves to every station every single day, But within a single day, they were sort of assigned they sort of picked and choose which station they wanted to be a part of that day. And by the end of it, it really allowed them to sort of, really get comfortable with a lot of the bedside tests, or, really focused in on each particular station, rather than, going through the entire thing. And like Julia had mentioned, it really just allowed everyone to be involved that was there.
So talk me through, after the patient went through these stations and you were to the point of diagnosis and counseling, how did that go? Did you have an interpreter there? Did you provide information?
So we had, as a group, all 10 of us, we had 3 interpreters. And it was really called, they were called on where needed most. So it wasn't uncommon for us to start with an interpreter and then for them to get called to the hearing aid room, while they're doing Verifit or what have you. And then a different interpreter show up in the middle of our assessment and just help out. All of them were Ukrainian, so they all spoke the language, and they all were able to accurately translate everything that we were, conveying to them. Especially, really, Julia had mentioned that, we sort of got in the habit of, and we got really efficient at, giving instructions non-verbally, but, at the counseling part of it, that's where we really needed the interpreters, especially if we, had significant findings. And so, yes, we did have an interpreter for each, patient when needed, that allowed us to communicate exactly what was going on. We brought, images of the ear and, wrote in Ukrainian on the sheet, the balance system. Well, we can get into that, but the vestibular system, and then the hearing or the auditory system. And we really just tried to communicate as effectively and clearly, and just really ensuring that the patient understood the message and that nothing was lost in translation. And we felt like things worked out actually really well. One of the things about the inner ear balance system that we were quite surprised. Julie, do you want to share this story? I feel like it comes better from you.
Yeah. So obviously, like Daniel said, we had 3 main interpreters throughout the week, and one of them just happened to frequently be our primary, I guess you could say, throughout the week. And I think it was like the 2nd or 3rd day, something like a few days in, probably halfway, where we had this nice diagram where we circled the inner ear and we pointed to the hearing organ versus vestibular, and had one of the interpreters write balance hearing, just to explain the anatomy in a very vague way, essentially. And so we'd been just saying, your balance system, blah, blah, blah. And she literally stops us one day and was like, "Are you talking about the vestibular apparatus?" And we're like, "Yeah." And she was like, "So if you say vestibular apparatus instead of balance system, people are going to totally know what you're talking about." And we were like, "What?" It was amazing. But you say that to someone in the US, where there are vestibular centers all across the country, and people still don't even know what that means. But if we said it in Poland for all of these Ukrainian refugees, they were like, "Oh, totally. No questions asked."
That's awesome.
We were like,
clear account, water there.
Absolutely.
Right? And as soon as you said that, counseling went so much smoother because there was less confusion.
Yep.
Balance can be a very vague term, but
Totally.
vestibular apparatus, they knew.
That's amazing. Well, Daniel, talk to me a little bit about, how many patients you saw, what were some of the main diagnoses and or trends? And I know this will eventually, I think, be written up for more details, but give us some high level what you saw.
Well, we saw 53 patients in 5 days.
Wow.
And 6 the first day. So, 47 the other 4 days. And I would say each assessment ranged, as far as duration, anywhere from 25 to 35 minutes, to complete the entire assessment. Some patients obviously needed more extensive counseling. than others. I want to say that we had somewhere that we designated significant cases anywhere from 35 to 37%. And we designated significant cases being somebody, had, significant symptoms. They had symptoms of dizziness. They had symptoms of balance, or they had imbalance. Cases that we identified as, having a true vestibular impairment, BPPV, you name it, or vestibular migraine. So we sort of designated that as what we would call significant. I want to say that we had 4 patients out of the 53 that we identified as having just classic vestibular symptoms or vestibular impairment once we finished the testing. Many of them actually was on the, we ended up finding the impairment on the same side as their poor hearing ear, which was nice confirmation. We had 3 cases of BPPV, I believe. We definitely had 1 or 2 central cases that we weren't, patients that we weren't even able to get through ocular motility. And then we had a handful of patients that had that had significant imbalance. And so I will say that number is probably an underestimate, just given that the sensitivity of bedside. So we didn't necessarily have all of the, we didn't have VHIT, we didn't have rotational chair, we didn't have calorics. And so I'm sure that there were some that we missed, but the ones that we identified, I mean, we were, cross-checking across, spontaneous head shake, head thrust, DVA, we were certainly, at least had, at least, 2 or more, clear vestibular signs that we were able to identify during the assessments in which, for the patients that we identified an impairment in. So I would say that's pretty high level, what kind of our findings for the week on just those 53.
Now, talk to me a little bit, and maybe they didn't share as much of this information, but functionally, what were some of the activities that they were trying to get back to, and maybe this is just my ignorance of knowing, because there's such a wide spectrum of refugees, what they're doing, but are many of them doing some sort of work, back to work, traveling, still kind of being between countries? Did you get any insight on what they were trying to get back to as far as activity?
I know at least many of them were not able to go back. There were a few that were able to, get fit, at least with hearing aids and go back to Ukraine. But many of them were at least here for, a significant amount of time.
Right.
There were certainly those that, worked in Poland, but, as far as, functional activities that they were actively trying to get back into, not necessarily much detail I can provide there.
Sure.
It's, Julia, any insight on that?
Yeah, I feel like we didn't get that much information for that, but the majority of the patient population that we saw, their goal is to be able to return to Ukraine when it's safe to do so. So this is 100% temporary for them. And so many of them are experiencing these symptoms. So it was nice to be able to help them in this temporary situation that they're in.
Absolutely. And you think, of course, hearing is the same way, but especially with dizziness or balance concerns, especially if you're a transient population and you may be moving in the future, it is critical that you are not dizzy or not imbalanced, because you have to take care of yourself to get yourself where you want to be. So I was just kind of curious if you had learned any more insights from that.
Yeah. And you know what, this was also kind of our first go at it. I think
Sure.
This is a door that, we opened and, definitely want to continue to try in every effort to keep open, just because of how successful, this first trip was. I will say that we had to sort of explain to them the purpose of the testing.
Sure.
You know, many of them had, or all of them actually, you know, had significant hearing loss and were coming there for a very specific purpose.
Yeah.
And so after that, you know, we sat them down and we just wanted to make sure, you know, given the hearing loss, we want to make sure that the vestibular apparatus is now is working okay. And so, you know, once we explained why we were there and what we were doing, you know, many of them, you know, were on board with testing. And so, you know, the way that this worked is it was advertised as a hearing mission. And so I imagine that, you know, us also advertising, you know, hey, if you're dizzy, if you're imbalanced, you know, come here, you know, try to, you know, see if, you know, if there's anything that we can do to help. I'm sure at that point, you know, certainly, you know, we could, you know, certainly help more individuals or at least recruit or invite more in, you know, refugees that have these specific concerns.
Yeah. So I know you mentioned that you had given out, you know, specific PT exercises and handouts that you had got, you know, from Vanderbilt. Talk to me about, did you have the opportunity or did you want the opportunity to connect to other medical professionals in the area? Like normally vestibular audiologists, we may refer to neurology or audiology or some of these specialties. Do you feel like you needed those connections or wanted them or made them?
So, of course, I mean, one of the main goals that we were trying to do months prior to this trip was trying to get in contact with a local ENT, local neurologist, somebody in the area. Unfortunately, we didn't have much luck, especially one that can provide, you know, services to the Ukrainian population.
Sure.
And so we sort of went over there and we wanted to try to give them, you know, as much information as we possibly could to help them as much as we possibly could. Because of course we would have definitely liked them to have some type of follow-up. And so prior to the trip, we translated a bunch of handouts that our PT colleague was able to provide. She actually sat us down one afternoon and kind of went through, okay, this is how I typically counsel for VRT. This is how I hand out these. This is how I prescribe these exercises and which situations, you know, just mainly, you know, you want to challenge the patient, but you don't necessarily want to put them at risk. Yeah. And so, yeah, I would say that certainly we wanted to have some type of follow-up, but there is an opportunity for us to go back here in November. So we'll at least be able to follow up with the refugees that we were able to test this go around. We're back in June.
That's amazing. Yeah. And I think that's not always something that we even get with our patients in a traditional clinic is the ability to follow up. So I think that's really nice and awesome.
Yeah. I mean, one very unique aspect to this is, especially as an audiologist, is, you know, any audiologist that's really in the vestibular assessment arena is going to see a patient and then really never see them again, unless they're, you know, repeat BPPB or, you know, BPPB or something along that line.
Yeah.
And I think it really gave a unique perspective and a continuity, I think, you know, a complete spectrum of care that audiologists and audiology students rarely get to see. You know, we certainly for the VRT exercises, it was simple, the VOR ×1. It wasn't anything that we didn't want to give anything too complex at this point. Sure. You know, for those that we identified clear impairments on, we wanted to give them just straight, you know, VOR ×1 exercises, which you know, are pretty simple. We actually, Julia helped me laminate a bunch of little target X's that we were able to give to them to take home to do on their own time, you know, 2 to 3 times a day until they felt better. And so my hope is that when we go back, you know, many of these patients, or at least the ones that we either gave VRT exercises to or we treated for BPPV, you know, hopefully they're doing much better this the second time around.
Yeah. No, that's amazing. And I think it's really cool to see and hear how the trip actually went. And, it's pretty amazing how much of an impact you could make. I mean, could you imagine seeing 53 patients in 1 week at Vanderbilt? You get
oh my gosh,
so tired. But, that's pretty amazing how much you could make an impact on. And even if you just help one person, that's still incredible. I love that.
Yeah.
Go ahead.
No, I was going to say, not only did this really have a clear, philanthropic impact for them, but I think this really opens and expands and really, expands upon what's possible in vestibular audiology, especially from an educational standpoint, and, research standpoint. And, I think it opens up a lot of doors just, taking so often our patients coming to us for these tests. Not only are, these tests hard to find, and they're very niche and, spread across certain areas of the country, but they're always also just coming to us. So you think about the types of patients that aren't coming to us, the ones that don't have insurance or the ones that may not be as mobile. And so to actually go to the patient, I felt like it was a very, it just opened up my eyes, I think, to, what's possible in this field.
I also we talked tons about that on the trip too, how, bedside testing is the foundation for all of the tests that we do at Vanderbilt and other vestibular clinics do. And, you have all of this fancy equipment, and that is ideal, but it's not 100% necessary to get some information. Obviously, it's not going to be as sensitive, but, even with just a pair of goggles in 1 week, how much we saw across the world. But, there's places in the US that don't have major centers, and it is so doable. And it also is just so beautiful to be able to help with that treatment aspect, like Daniel was talking about. That's not something a student sees in clinic. We refer elsewhere, but the counseling and even just showing them how to do one of the exercises and making sure they physically right now can do it before they go home with their handout was such a unique experience. And like he was saying, it really broadened the idea of what vestibular audiology could be.
And I think regardless, I think we're talking very all or nothing, even from an equipment standpoint, but there's many people who budget-wise, they can't get all the equipment. So it's nice to be like, you don't have to do all or nothing with tests. Like, you can use what you have and fill in the cracks. It doesn't mean you can't assess balance because you don't have posturography. It doesn't mean that you can't assess, whatever, because you can still do some of these tests. And it's really our job as a clinician and as an audiologist to still care for the patient with what we have. That's where our degree really matters. And, equipment is a tool to be able to help patients, but it's not the only tool. It's your brain plus the equipment that makes it most powerful.
Definitely. I feel like, I absolutely have a new appreciation for bedside testing after going on this trip, because it was, you're out there, you're very limited, and, you had to make some clinical judgments based on the things that you've seen. So, in a short amount of time. And so it was a very unique aspect of the type of, we think about bedside tests, and, we talk about how, they're not as sensitive as some of our objective measures, but, it's better than nothing. And, I was cautiously optimistic, going there. I was a little nervous. I was like, I hope I'm not completely off here. And there's a reason why, there's not vestibular humanitarian trips out there. But the very first patient that we saw, just a clear, right, uncompensated impairment. And I was like, okay, we're on to something.
We're good to go.
Okay.
We're helping one person. That's
yeah. So,
and that being said, you'll get a V-hit for your next.
I know. So yeah, I was definitely okay. Like, all right, that's a sign. We're good to go.
So just a couple of questions for each of you just to wrap up. So Julia, talk to me now that you've had some time away back from the trip. How do you feel like, what's one thing that's changed either your educational perspective or maybe even future career goals from this trip?
I definitely think how comfortable I am in clinic and how I think about patients as a whole, especially for a balanced clinic, it's so much more enhanced. And I feel like I think deeper about all the specific aspects. Like the other week in clinic, I was like, I want to do DBA. Like that's not something we typically would do in our test battery, but using what I've learned and how you really should adapt to each patient's specific needs and findings, and how, we have great protocols, but it should be focused on the patient. And, I feel like that is a big takeaway for me, but also that whole treatment aspect of wanting to either hear about the follow-up with patients. That's something I love about the other side of audiology, is the continuity of care. And through this trip, I was able to see that within Vestib, which I really, really loved.
That's amazing. Yeah. And I think that's an incredible perspective to be able to look at each patient individually, because I think it's easy to look at all patients the same, which clearly they are not. So that's awesome. Daniel, what about you? Do you feel like this has changed your career goals, your research focuses? What are your thoughts?
It's definitely related to, I think, my overarching goal in this field, and that's to, I can't help but think about going to the patient. I think that kind of solidified, going on this trip really helped me solidify that. There's certainly some aspects of some of the other research that I'm doing in TBI that falls along the same line of going to the actual patient. So this trip was a very nice kind of plug-in to that overall mission. And so I would say certainly that this trip has really changed my view on what's possible for this field. I'm certainly one where I'm trying to see, what are some of the different ways that we can help move the field forward. And this trip, and an example of what this trip means, is I think has it all. And it really can, in and of itself, immediately push the field forward, because we know that there aren't a lot of vestibular centers. We know that audiologists are few and far between, and anything that can be done to serve more patients, I think, would be beneficial for everyone. So, and really beneficial for audiology. So I think there are so many elements of this trip that were unique and is an example of moving this field forward to where it needs to be.
Absolutely. No, I can definitely feel that just from talking to both of you, that you both have been impacted by the trip, and I think it's going to affect our field for the positive. So last question for each of you. What would be one piece of advice that you would have for somebody that wants to go on a similar trip, whether that's, preparation, logistics, or even just, confidence while you're there? What would be your piece of advice? We'll start with Julia.
Okay. 2 pieces of advice. The first,
breaking rules.
I know. But unrelated to the other. The first I would say is just ask questions. This trip probably wouldn't have happened if Daniel didn't say, well, what about Vestib? What about balance? So, there are many, I feel like, hearing-oriented humanitarian trips. And if you don't ask about Vestib, you'll never know if that was something you could have possibly done. So that would be one, asking questions about if it's possible, but then also just asking questions to people who have gone. Something that we really were lucky with is that there was groups that have previously gone on this trip to Poland. So asking them questions about their experiences, what went well, what didn't go so well, what could be improved upon, just to, understand what you're getting into, and then so you can prepare accordingly.
Yeah. Gosh, I have so many thoughts, but I'm going to try to boil it down. So, if I could define this in one word, it's all connection. It's connection with other professionals, connection with the patients or the people actually that you're over there to serve. And the other thing is you learn, of course, we learn so much about everything that's going on over there in this current situation, but to actually hear their stories and talk to and understand the hell that they're going through, it's like, in and of itself is, it really just puts things into perspective. And so, anyone who's interested in going, or, going on a trip like this, go to, different, try to find those people that humanitarian work. I know there's a conference coming up, I think in California maybe, but it's the Global Hearing Coalition. So there's certainly a lot of humanitarian audiologists and humanitarian researchers that are at these types of events. So really getting into contact. Anyone's more than welcome to contact me. Certainly I have that connection with Dr. Chung and her group. So there's other groups from other countries, like in Brazil. There's universities in Brazil that have gone on this trip. There's so much to do. And then the other thing I would say is, it's okay to take that leap. I was certainly nervous. I had mentioned this before. If I was like, why hasn't anybody done this? Like, what's going on? But yeah, what's the catch? If you see an opportunity to make this profession better, but to also make people's lives better, take it. And chances are no one's just had the courage to take that. So, certainly that's would be my advice.
I think it's amazing. And Daniel, I know I told you this, and half the reason I wanted to dedicate an episode to you is I think what you did is incredible. And I really do think it's paving the way. I mean, I don't know of any other trips that have happened similar to this. Maybe somebody will speak up and let us know if there is one that has. But even just showing that it's possible, from a, logistics, being able to actually provide the evaluation, provide the treatment or some suggestions there, I think is a huge barrier to be brought down. And it's super humbling for us to be able to get out of our clinics and out of our comfort zones where we have all of our things how we like it, and get out and serve the population. That's why we joined this profession. We wanted to help people. And I think what you're saying is so humbling, and, helping a population that's 100% in need. And there's people even within the US that are probably in similar situations. Absolutely. And so I think it's just amazing. And you guys should be really proud of yourselves for not only making the trip happen, but going and investing, in this group of people. And hopefully it's the start of a many.
Yeah, I really hope so. Again, and, come check out, either a AAA. We're hopefully going to kind of lay down our method, to kind of lay the groundwork for anyone else who wants to kind of put something similar together. We're hoping to disseminate some of our method and just some of the things that we did, and just share our experience really, maybe at, some of the upcoming conferences. So be on the lookout for that as well.
That's amazing. Well, thank you both for joining. Thanks for sharing your perspective. If anyone has any questions, feel free, of course, to comment or message us. We're now on YouTube, so feel free to comment on that video if you have any questions, or you can always send us direct messages on our Instagram account, and we will get back to you. And if you want to hear the perspective from Daniel, more in that teaching role, if you want to hear a perspective from Julia or one of the other students, I'm sure they will all be happy to share their experiences. So check us out on Instagram or YouTube, and feel free to leave any comments, encouragement, or questions. So hopefully you guys have a great rest of your week, and thanks for joining us.
Thank you for having us.